Thank you for joining us for the first of 3 webinars on reducing hospital readmissions by exploring the use of adherence management ADAM coaching. In this first webinar, we will be looking specifically at the BEARS Medical Adherence Assessment Scale, or B-MAAS, to identify patients who are at risk for not following their plan of care, either upon or shortly after discharge. Hello, my name is Christopher Preisler, and on behalf of our founder, Dr. Bob Wright, we begin this series on reducing hospital readmissions. Dr. Wright has spent the last 38 years using an applied behavioral approach across many different environments. In addition to his many roles, such as RN, audiologist, hospital administrator, he also helped design and implement one of the first brain trauma centers in Florida, and was also the director of the Threshold Center for Autism. He has trained staff, providers, caregivers, and even parents on the use of applied behavior to provide better outcomes. Non-adherence was not created in the 21st century. It has plagued providers for as long as people have lived and sought the advice of healers, shamans, and physicians. As an example of the problem, Medicare reported in 2010 data discharging over 13,500 patients a day. The readmission rate, however, was 20% of that, or just over 2,700 a day. Over the course of that year, almost 1 million readmissions were reported. CMS has set a goal to reduce the number of readmissions by 20%, and we would need a mechanism to reduce 200,000 patients from being readmitted. But that would be for the 2010 numbers. The goal to reduce that number by 20% would mean that we needed to find a mechanism to reduce 280,000 readmissions. The healthcare efforts to change the discharge care process and increase patient education have not contributed significantly to the reduction of readmissions that is required by CMS. If we know that at least 50% of our patients are not going to be adherent, is there a better way to predict who, upon being discharged, will do as we ask, or who will go home and immediately return to their old habits that led to their admission in the first place? There is an evidence-based tool that can evaluate the behavioral outcomes of a patient before they are discharged and become an effective way of identifying those patients who are at risk for non-adherence. It's the BEARS Medical Adherence Assessment Scale, or B-MAAS. So let me say this in the words of the World Health Organization. In every situation in which patients are required to administer their own treatment, non-adherence is likely. Consequently, the risk for non-adherence for all patients should be assessed as part of the treatment planning process. As I said before, when left to their own with a need to follow their care plan, it is highly likely that patients will not follow their doctor's orders. Throughout history, providers have been advised of the importance of learning how to assess and detect non-adherence, but there has never been a consistent strategy or reason to go beyond the walls of the hospital to address this problem. Now, CMS and the Affordable Care Act punishes providers if the patient is readmitted within 30 days of discharge, claiming that the providers are not providing quality care, when in reality it is the behavior of the patient that caused a good majority of readmissions. And according to the World Health Organization, patient education is not enough, and non-adherence detection needs to be implemented. The B-MAAS is the tool to quickly assess a patient during the admission process or any time thereafter to determine the risk factors of the patient for their non-adherence. So the biggest question is, why are patients non-adherent if their care plan will help them? Or who is at risk for being non-adherent? Back on the slide 4, we saw that an average of 13,500 patients every day were being discharged. In a traditional approach to healthcare, we will assume a traditional role of provider to diagnose and prescribe. We provide a plan of care, and our patients are released from the hospital to follow that plan. In this approach, shown in Chart A, it assumes that all patients start, upon discharge, as adherent. It is very evident from the chart, however, that before the first month of post-discharge is complete, adherence falls off and continues to fall off throughout the next year. It eventually approaches the baseline behavior of not taking any medications at all. In a 2012 UK pharmacist training study, Dr. Grace Lomax conducted an experiment regarding the use of enhanced patient training, reinforcement, and support. In Chart B, as well as in our own approach, It assumes non-adherence from the beginning and reinforces adherence over time. Her findings strongly support that working closely with the patients and offering reinforcement had a significant impact on adherence when compared with control groups of patients receiving less enhanced support and those who received no support. Positive reinforcement did have an impact on adherence. An interesting fact that also came out of the study was once reinforcement had stopped, behavior continued to improve for a short time and then began to return to baseline after 30 days of stopping the reinforcement. This phenomena happens when a subject is expecting reinforcement, but when it does not come, behavior eventually returns to baseline. There are any number of predictive tools available that can be used to help identify patients that are at risk for non-adherence. Moriski presented his predictive scale in 2008, and it is popular in medication adherence. The M-MAAS 4 and M-MAAS 8 are simple and practical to use and can identify some patients who may have medication adherence problems. It is, however, completed by the patient and can lead to inconsistent or untrue answers. With the B-MAAS, we wanted to create a tool that is easy to use and could be done by nurses or case managers. Each of the elements has been proven to be related to non-adherence. Using the touchscreen, nurses or administrative staff can select the various categories and totals are automatically calculated. The primary goal of this simple tool is to quickly and efficiently identify the at-risk populations. So let's take a look at some of the categories and how they can give you a very quick assessment of the potential for your patient to become non-adherent. Predictive scales are at times like looking into a crystal ball to see the future. The difference with this tool is that each category is based on more than 30 years of research into the factors that contribute to patient adherence or non-adherence. Points are added to a total score based on the answers. Risk assessment is based on the total number of points. The higher the number, the greater the risk of non-adherence. The first 4 categories are simple 0 or 1 point questions that can generally be answered before meeting with the patient. Married people are shown to be more compliant, mainly because their spouses will nag them if they're not. Females tend to be more compliant than males. The question related to, is the patient motivated to improve, is somewhat subjective and can generally be answered by asking the patient, how do you feel about your current health condition? Again, remember, we are primarily interested in a person's behavior, not what he or she thinks or feels. So this question is a simple yes or no, 0 or 1, to determine if there may be a behavioral defiance problem. Studies on ethnicity are quite varied, but essentially boil down to Caucasians have a slightly better adherence rate than other races. So again, this is just a 0 or 1 answer. It can contribute to non-adherence, but more in-depth reasons will be discussed in future slides. Now we begin to assess more significant factors that contribute to non-adherence. Education is an important element related to understanding their disease process and the things necessary to adapt and overcome their illness, if possible. Lower education levels means a patient is at higher risk for not being able to understand a discharge plan. Age is inversely related to points because the older the patient is, the higher the likelihood that someone will be monitoring or assisting in their plan of care. The highest risk population are the younger patients in between 20 and 49 bracket. For the most part, younger people believe themselves to be invincible and need to be convinced that proper dieting, exercise, and medication regimens are important for long-term outcomes. Sensory impairments, such as hearing or vision, are important adherence factors when it comes to understanding instructions and being able to read prescription labels. Vision can be quickly assessed without being an optometrist by whether or not they can read without their glasses. Hearing can be assessed by whispering a question to a patient. If they understand the question, they do not have a hearing impairment. Normal speech is 65 dB. If the patient can understand the spoken voice but not the whispering voice, you can suspect a mild hearing loss. If you have to raise your voice 85 decibels for a patient to understand you, then you can suspect a moderate hearing loss. Again, these are not for diagnostic purposes. They are simply to determine whether the patient is at risk for being non-compliant with a care plan. The next 4 areas are also somewhat subjective, but need to be addressed by the reviewer. A medical history may indicate some sort of memory impairment. Other patients may have anger or defiance issues related to their diagnosis and may choose to ignore the plan of care. Indications of intentional defiance can be picked up during the interview process with the patient. Much of the healthcare being offered today is episodic. There are very few opportunities for a provider to develop a patient-provider relationship beyond the documented visit. The more frequent a patient sees a particular provider, the higher the likelihood to develop a personal relationship, which lowers the risk for non-adherence. Side effects associated with taking a particular medication will also have a direct impact on whether the patient is motivated to continue with their care plan. Older patients with chronic or persistent disabilities may have difficulty with manipulating medication bottles or opening blister packs. Diseases with low or no symptoms, such as hypertension or high cholesterol, often lead patients to believe that they no longer need to take their medications. The more aware the patient is of their symptoms, the lower the risk of non-adherence. With 20% of the population having some sort of mental illness, this plays a part into each individual patient's assessment of risk. Again, we are not making a diagnosis. We are simply assessing risk for non-adherence. While 8 out of 10 patients will essentially be normal, keep in mind that out of the 20% with mental illness, there will be a range from mild with only a few symptoms to extremely mentally ill requiring supervision or hospitalization. Attitudes about their disease recovery plays an important role. The patient may believe that their disease is some form of higher being's retribution for past sins or an opportunity to make them stronger. Patient attitudes can range from very positive and hopeful to one of hopelessness. Although it is not the belief that we're concerned with, but whether or not their attitudes can or will affect their behavior. Understanding of the disease process and the management of their disease is a critical element of all patients. Whether you are an intake nurse or a discharge transition care team, keep in mind that your patient has the disease, and he or she needs to both own the disease and the behaviors necessary to manage the disease. People who have little understanding of the process are at significantly greater risk for non-adherence. We also need to look at 2 specific lifestyle habits that contribute significantly to morbidity and mortality. People who are addicted to alcohol, drugs, or cigarettes have already demonstrated that their health is not a primary concern. Continuing in these addictions will have long-term effects on patients. Doing either or both significantly increases the risk of non-adherence. The number of any medications and the complexity of the regimen will also contribute to non-adherence. The 21 data points of the B-MAAS are focused in 5 primary areas of interest with a greater emphasis in the areas of behavioral, such as what a person does, and cognitive, such as what a person thinks, feels, and believes. Demographics, physical, and environmental also contribute to non-adherence. All of these categories pulled together as a whole give us a very accurate predictive tool of those patients who are at risk for not following parts or all of our plan of care after discharge. Once identified, steps can be taken to help the patient overcome some of the barriers that contribute to their non-adherence. A significant difference with our approach to adherence is that we look at the consequences of what we ask our patients to do. This is particularly true with outcomes that the patient may consider negative or punishing. We'll talk more about the consequences of our plan of care in Webinar 2. In addition to the B-MAAS, if we suspect the patient has other physical or mental factors that could lead to non-adherence, we can drill down further with our B-PAAS, or Bear's Physical Abilities Assessment Scale, to look at specific patient capabilities and impairments. For example, we can explore the impact of receptive or expressive language abilities on behaviors needed for adherence. Keep in mind again, these 2 tools are not diagnostic in nature. They are simply predictive for assessing risk. These forms take 5 to 10 minutes total to fill out, but can be used as a great starting point for turning a non-adherent patient into one who can and will adhere to your provider's plan of care. The adherence management approach to patients following care plans is an approach that begins with an assessment of risk. At-risk patients then have their plan of care analyzed from the patient's perspective for the negative and punishing consequences that may be associated with that plan. It is very clear that all providers prepare their plan of care based on experience and industry protocols. The science is sound, the methods are correct, the medications are effective, and the patient is expected to follow the plan to the letter. But for more than half of the patients, there are elements in the plan that are punishing from their perspective. These are forced economic and behavioral choices that result in the patient making a choice not to follow the plan. There may be other alternative courses of action that could have been taken, but without identifying the red flags and coming up with an alternative plan, that patient is at high risk for non-adherence. The consequence analysis then will be thoroughly reviewed in the next webinar, and we will show you what we mean by taking a look at the plan from the patient's perspective and the impact that can be seen through their eyes. Looking at the plan of care through the patient's eyes is perhaps the most important component of what we do. From the provider's perspective, each part of the plan is essential to the patient and their recovery. But what about from the patient's point of view? In the next webinar, we'll be looking at how the discharge orders are perceived by the patient and the home healthcare providers. Many of the things that we ask our patients to do make perfect sense to us, but in the hands of the patients, these plans may represent punishers and have negative consequences that the patients are just not willing to pay. So I want to thank you for attending this webinar, and if you have any questions regarding the B-MAAS or B-PAAS or our applied behavioral approach to improving adherence through our ADAM coaching, visit us on the web at www.bearstherapy.com. Thank you.